All right, so I want to welcome everyone back to our second session of Thirsty Thursdays. And our focus today is going to be doing questions on next gen case studies. Yes. Some of y'all are like, the case studies. And some of y'all are like, I'm good with them. But I'll tell you, the more that you practice, the more that you're going to become more proficient and more comfortable with doing them. So that's our focus today. And we're going to dig into a few cases, and I am looking for all of you all that are participating, that are here in the room or watching this video after the recording. I'm looking for you to participate and get involved. All right, so we're gonna get into it. And once again, Thirsty Thursdays. Our focus today is to take care of patients by doing a few case studies today. All right, so we're going to do that together. And with that said, I just want to highlight a couple of strategies for the room. And I actually did send an attachment. In the email that went out to you, I attached a few tips and tricks and strategies that may prove to be helpful when you are answering these questions. So, just to highlight a few, I simply want you to keep the following in mind. The way you are measured on these case studies goes according to that clinical judgment model, which is actually on my next screen. I'm going to refresh you on what that looks like. So we want to try to keep that flow and follow that judgment model, clinical judgment model, as we're doing these questions. And we want to make sure we're reading the scenario carefully to understand what is happening, because a lot of the times the scenario is going to give us the history, the patient's assessment, lab values. So essentially, after they give that to us, then we are going to be asked questions, essentially, questions that may be posed in the form of multiple choice, drag and drop, matrix grid, and or fill in the blank, right? So we've seen these types of questions before because we've been practicing them. But try very hard, very very much so, to follow that clinical judgment model, be aware of what that scenario is asking you. So read it all and take a systemic approach. This may be starting with essentially keeping in mind the ABCs, keeping in mind Maslow, keeping in mind safety principles, and always thinking about your nursing scope. All right. The nursing process is essentially that ad pie, following assessment, right? Leading into diagnosing, to planning, and then implementation, and then evaluating. So, again, the nursing process kind of aligns with that clinical judgment framework model. All right. Pay attention to key things like lab values. Lab values can tell us a lot about what's going on with our patient, and so can trends. All right. So we're looking for high and low lab values. Those indicate potential problems that the patient is having, right? Like infection, like hypokalemia. And then the trending data indicates that possibly our patient's condition is worsening, like a worsening blood pressure or a declining oxygen saturation, right? So, again, those labs tell us a lot of information. And I want you to always keep in mind, you've got to manage your time. You do. And these case studies present with a lot of information, but managing your time wisely is key. Make sure you are reading the questions carefully, pulling out the things that matter, and more times than not, the abnormal findings, they matter. That's what matters, right? Because typically patients don't come to a hospital or to a urgent care or to a clinic seeking help for normal things, right? They don't do that. Where do they do that at, right? So you're going to be kind of keeping that mindset, looking for the things that are abnormal assessments and abnormally abnormal in comparison to the diagnosis. All right. So again, we're keeping our eye on what matters, and that's going to help us with managing our time. But don't rush though. Okay. I don't want you to rush this thing because you could miss some things. All right. And make sure that you're practicing. So in and and about beyond this session, um, practice, and that's what a Q bank will afford you the opportunity to do, and that's to practice. And luckily for you all who are in my course, you have a very solid Q bank that's giving you the ability to do just that, and that's practice. And this week, for my February 11th cohort, that's what it's all about. It's all about doing practice next gen case studies. All right. So practice is not going to necessarily make us perfect, and we don't have to be that. Thank you. Thank you, Lord. We don't have to be perfect, but we do get better, right? When we practice. So that's what I'm saying to you. And stay calm through this thing. All right. Don't get overwhelmed. Don't get flustered. Approach the questions with logic, right? Treat these patient cases like they're actual patient cases. Trust your nursing knowledge, trust your instincts, and try not to second guess yourself. All right. All right. So that's the strategies here. All right. And with that being said, this is just a friendly reminder of that clinical judgment model. These are the 6 domains that the NCLEX measures you on when you are testing, and they are measuring your ability to be able to successfully, at an above passing standard, recognize patient cues, analyze them, prioritize the problem, come up with some solutions, take some actions, which means to carry them out, uh, and then evaluate, right? Did it help, right? And this down the bottom are your strategies that kind of helps you to answer each of those domains. All right. So again, we're going to get into it, and we're going to do it. Our rules today include 2 minutes. Yes, I said that. 2 minutes per question. Ouch. Yeah, I said that. This 2 minutes will start once I've finished reading the 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 scenario, or finish reading whatever on that screen. All right. And why 2 minutes? Because that's what NCLEX says. 1 to 2 minutes on a question, and that's not for an exception of the case studies. It includes them. So we're going to try to stay within that window, and I want you to do your best. All right. And put your answers in the chat box. There may be a point where I'll specifically tell you how I want you to put it into the chat box, and I want you to adhere to those directions. All right. So your answers will go in the chat, and any discussion that we may have will be at the end of when we're done our patient cases. All right. It's 3 of them today. When you're not speaking, please make sure you are muted. All right. Because again, I'm recording and I don't want to be a disruption to others. And if you are on camera, please try to stay in one place, because that can be very disruptive to others that are on. All right. If you're moving around, just take your camera off for the sake of distraction. And once again, we're going to get into it. And I don't want you to overthink, but I do want you to think. And I want you to think critically. All right, so we all nurses are entering into the Nurse ED 101 hospital. And guess what? We all came to work today, and I appreciate you all for showing up. And we are a part of the float pool in this hospital. All right, so our first patient case, it's going to be taking care of a patient dealing with substance abuse. All right. So that's going to take us to our first case, followed by our second case. We're going to be dealing with the patient that has uh, a DVT, which stands for deep vein thrombosis. And then our final case, which is going to take us onto the medical units, is a patient dealing with heart failure. All right. So that's what our plan is for this hour. And so let's go ahead and get into it. And at the end of our cases, we'll have a discussion, if anything, wrap it up, and then I'll give you back your day. All right. So that's the flow for the day. And with that said, we're going to go ahead and pivot on to seeing our first patient today. All right. All right. I hope your nursing caps are on. We get ready to have some fun. All right. So we've got our first patient case. All right. And I will actually try to make this a little bigger. All right, we know that this is a one of one, a singular type of case. All right, and we have a scenario, we have a summary, and we have an assessment. But what I tell you as a strategy is to come on down to the bottom so we know exactly what they want us to answer here. So here's what they're asking us. They're saying the nurse is reviewing the assessment findings with the healthcare provider. Okay, so nurse and doctor. So we're talking to the doc. All right. And they basically want us to complete the diagram. And for many of you, you know exactly what this type of question is. It's the bow tie, right? It kind of looks like a bow tie. And so they're wanting us to, based on the assessment findings, they're wanting us to kind of figure out what's going on with this patient, right? Remember, this is the substance abuse case study. Is this a patient who is dealing with a benzodiazepine dependency? Or is this patient dealing with an opioid dependency? Or are they dealing with alcohol dependency or methamphetamine dependency? All right, so it's a good thing right here, maybe even to take a picture, a screenshot, or jot down real quick, because when you're reading the assessment, we want to keep these in mind. Okay, so with that said, we're gonna go on up. All right. Benzo, opioid, alcohol, methamphetamine. What are they dealing with? All right. So let's go ahead and read the assessment. Let's check it out. And before we do, let's learn a little bit about our patient. So the nurse is assessing a 27-year-old client who's presented to the emergency department with concerns of, here's some abnormal findings: nausea, vomiting, diarrhea, and muscle pain. But how many of you know that that could be anything? Which is why they gave you four different options below, right? That could be anything. So we've got to comb through this assessment a little bit more to find out, what does the assessment findings align more with down below? Does it align more with an opioid, alcohol, methamphetamine dependency? All right. So let's look at this. So on the assessment, the client 27 presents to the ER. Once again, nausea, vomiting, diarrhea. That would be something that I would be jotting down as abnormal findings. Their pupils are also constricted. You do need to know the difference of what constricted and dilated, what that could symbolize. Okay. But this patient's pupils are constricted. All right. The patient also stated they have significant muscle pain. That's abnormal. Okay. And they rate that pain 8 out of 10. Okay. Client appears also irritable, restless, displaying frequent yawning. Okay. Client also reports, here's some other information: loss of job 1 month ago. Could this be a risk factor for something? Why they're trying to slide in this piece? Also, that their spouse filed for divorce and they are currently homeless. This line right here is slid in there for risk factors. Okay. This basically means stressors. Patients dealing with some stressors, some life things. This is real. Some life things. All right. The client's hygiene on assessment is noted to be poor. So this patient's not keeping up with their hygiene. Admits the history of substance abuse, but here we go, denies current use and is just hoping for something to help their symptoms, which is what we just combed through. Their vital signs: blood pressure 138/94, pulse is 98, respiratory rate is 18, and the temp is 99.4. Vital signs looking okay. All right. So here's the thing: based on what the abnormal findings, right? The nausea, the vomiting, the diarrhea, the constricted pupils, the irritability, the restlessness, right? The frequent yawning, the risk factors, the hygiene concerns, right? A history of substance abuse, but they're not using currently anything now. They're looking for some help for their symptoms. What condition, okay, would you classify that this patient is most likely experiencing? And for this, I actually want you to put in either in the chat box, I want you to either type in benzo, opioid, alcohol, or methamphetamine. I want you to put in what you think. All right. So your answers are beginning to drop in the chat right now. Benzodiazepine, opioid dependency, alcohol dependency, or methamphetamine dependency. What is that patient's symptoms more so align with? Talk to me, drop it into the chat. Okay, answers are beginning to come into the chat. Okay. Once again, that patient was irritable. They had nausea, vomiting, muscle pain, constricted pupils, right? These were the abnormal findings that were noted on assessment, a history of substance abuse. What can we associate perhaps a potential condition as patient is experiencing at this time? All right. Drop in those answers. All right. I've seen a go between benzo and alcohol. Okay. All right. Opioid. Okay. Julia, I see you. Welcome. All right. All right. All right. Okay. All right. All right. So we've got a multitude of answers here. We've got alcohol, we've got benzo, we've got opioid. Okay. All right. All right. So I'm going to stop this timer here and we'll pause that for a second. And here's the thing, for those of you who actually chose that this patient was experiencing opioid dependency, you're spot on. Okay. You're spot on. You're spot on. This is what we would consider to be what we see above is an opioid, a patient who is displaying symptoms of opioid dependency and subsequently are withdrawing. He's withdrawing from the substance. And opioid withdrawal may begin as early as 2 hours after the patient last used that opioid. All right. And clients experiencing opioid dependencies and subsequent withdrawal may experience these symptoms, right? The fatigue, flu like symptoms. He's got muscle pain. That's flu like symptoms. The patient may also experience the nausea, the vomiting, as well as diarrhea. And here's a big one, constricted pupils. Constricted pupils. All right. They also experience irritability, restlessness, and frequent yawning. These are all the clues that are buried inside of this assessment note. All right. So that's what we see here. Okay. And so with that said, now that we've picked the the condition, what actions should the nurse take in this case? And so we have options 1, 2, 3, 4, and 5. Okay. And what I want you to do in the chat, I want you to type in the letter A and whatever your two options that you feel would be the best for the nurse to take in this case. All right. So if my answers are one and two, I'm going to drop in the letter A and then one and two. All right. So please kind of put that in the chat. And if you are also kind of moving over to the parameters, you're already thinking about what I want to monitor after I've implemented my actions, you can do the same thing by putting in the chat the letter P for parameters. Okay. And then your number 1, 2, 3, 4, or 5. Okay. And again, we have to pick two. All right. So give it to me. What you got? What you got? What you got? All right. What do you got? What do you think? Action wise, what should we be doing here? Action wise, for a patient who is withdrawing here. That's what's happening. They're withdrawing from an opioid. So, what makes sense that we would be doing or should do action wise to take? All right. Answers are coming in. All right. Answers are coming in. And so far, I see option one is a common denominator. All right. What other options should we be taking for someone who is opioid dependency? Okay. Opioid dependency, but withdrawing. Okay. All right. All right. I'm seeing more answers. And yeah, I see you, Johan, put in that parameter to monitor. I see you on to the next. I see that. All right. Yes. Okay. Okay. All right. All right. All right. Yes. Okay. So what I'm gonna do, I'm gonna take what's the majority that's coming in, and we're gonna discuss it at the end. So that's what I'm gonna do. And so far, I'm seeing more of the twos than any other option. I do see an option five to go ahead and get drug screen done, but for the most part, it looks like option two is the majority. So initiating an IV, applying a continuous cardiac monitor. Okay. Um, and if this is what we're doing on the action side, what parameters would we want to take or monitor on the other side of this? What makes sense? What will make sense? So go ahead and drop that in the chat. Does it make sense to monitor their nutrition and hydration status, cardiac, respiratory function, or any of these other parameters? Okay. What do you think? Yeah, it's hard to get this on two screens. It's hard to get it on the full screen. So, yeah. All right, give me some parameters. Awesome. All right, I'm seeing some coming in. What makes sense here? Okay, patient is dealing with opioid withdrawal, nausea, vomiting, irritability, muscle weakness, more muscle pain rather, like that flu-like symptoms, constricted pupils. Um, all these things. What would make sense that we would want to keep our eye on for this patient as they're now beginning to withdraw from this opioid? Okay. Okay. All right. All right. Twos and fours. Twos and fours. Okay. That's the majority coming back here. All right, we'll go ahead and take it that the cardiac and respiratory function is the primary as well as the seizure activity that's possible that could occur. Okay. All right. So this looks like once again more of what came in as the majority from the room. And we're gonna go ahead and hold on to it and keep it. We're gonna see how we did in just a bit. Okay. All right. So let's head on. to see our next patient. All right. So once again, I'm going to read. Ooh, we got a bow tie, another one. All right. So our next question is a one of one. And if we scroll to the bottom, we see it's the same thing. They want us to identify a potential condition. And once again, if you are moving along with me, it might be a good idea to even take a picture of this so that you know what we are doing or kind of looking for, considering the potential condition of dehydration for this patient, infection risk, sepsis, or bleeding risk. All right. And then we've got actions to the right and parameters to monitor, well, actions to the left and parameters to monitor to the right. All right. So we've got to go up. How will we determine what kind of condition or potential condition they have? By the assessment, by reviewing the assessment, the notes, right? And that's how we're going to figure out what this patient might be dealing with here. All right. So our job is to comb through that assessment and pull out some abnormal findings. All right, so this is our second patient. All right, so a nurse is in the acute setting at Nurse Ed 101 Hospital. All right, and they're likely on a medical unit, right? This is a 32-year-old client who's being treated for DVT, deep vein thrombosis. And what's the intervention? It's typically heparin. They put them on a heparin infusion. Um, and in this case, the patient's been on it for 3 days. Okay, so they've been receiving this heparin for 3 days and so forth. All right, so we're going to go to the note and we're going to be reading, looking for abnormal things, but we have a diagnosis up above. So again, if we identify some abnormal things or assessment findings in this note, if it aligns with the diagnosis, then we're good, right? We're looking for something though that might be abnormally abnormal. Okay, so even though it may be abnormal, but if it connects to the diagnosis, then that's different. But if it's abnormally abnormal in correlation to the diagnosis, then that might be our problem. All right, so let's say we can find that in this case. All right, so note happens at 10 a.m. and first line is about the vitals. All right, so the vital signs of this patient is 97.8, heart rate is 80, respiratory rate is 20, and the blood pressure is 118 over 72. The pulse ox is 98% on Vermeer. Those vitals, if you would agree, they look pretty good to me. No abnormal items there. The patient's skin is warm and dry. Okay, it's pretty cool. DVT site, left lower leg. Okay, left lower leg. That skin to that left leg is intact, but there is slight swelling noted in that left lower leg compared to the right. Now, this line that's highlighted is abnormal, right? But if it's abnormal and it connects to the diagnosis above, which is a DVT, then we're good because we would expect, right, the patient who has a DVT to have some slight swelling in the leg that's affected. And in this case, it's their left leg. They've got a little bit of swelling noted, no problem. All right. They are denying pain or discomfort, which is great. They have bilateral capillary refill that's brisk, which is good. That means they've got good blood flow. Oh, thank you. Thank you for that information. All right, hair growth is noted bilaterally on lower extremities, which is good. Hair is growing, which means that there's likely good flow, good perfusion to the area, etc. All right, the patient is able to move their toes, extremities without discomfort. The abdomen is soft, it's non tender. So, GI wise, we're looking good. The bowel sounds are present in all quads. That's great. The diet is being tolerated. The patient is voiding fine. So, GIGU looks like they're doing good. Their last BM was this morning and it was a formed stool. Wow. Listen, that assessment, great, right? Other than the little bit of swelling that was noted, right? Nothing really sticking out that's a problem here, all right? But take a note to this. Heparin is being infused. 16 units. It's infused by units, but it's per the patient's weight. So how much the patient weighs, it's based on that, right? So the patient is getting this infusion, all right? And based on their last PTT or APTT reading, it was 50 seconds. So whenever that was drawn, it might have been drawn maybe 4 hours ago, 6 hours ago, 8 hours ago, but now it's been drawn again, and look at the results. It's 82 seconds. All right, which basically means that if the patient, it's going to take 82 seconds at minimum, right? If the patient is cuts themselves, they start bleeding, we hold pressure. 82 seconds later, there will be a clot formed at that opening. That's a long time. Right? Versus the norm is about 20 to 30 seconds for any of us who are not on blood thinners or anticoagulants. All right. So I would say to you, my good nurses out there, what condition or potential condition or potential problem do we have here? And I'm going to try to put this on one thing. Yeah. All right. I kind of got it on one screen. Okay. Really. Yeah. So have we ran a patient assessment that is based on the assessment of, have we interpreted that this patient has a potential condition for dehydration, infection risk, sepsis, or bleeding risk? What does the assessment above most closely align with below? All right, what does that look like to you? What do you think? I want you to drop it in the chat. All right. All right. I see you, William. All right. I see you, you there. All right. Whatever the abnormal is, we want to match that with, okay, no problem. No problem, Joseph. All right. Whatever you want, that abnormal, we want to closely match that with 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 the potential condition below, right? And yeah, so far I'm with you. I see options. Most of you are choosing that this is more of an abnormality that suggests that this patient's at risk for bleeding, right? As evidenced by their current APTT results. All right. So if he's at risk for bleeding, what are we going to do about it? What actions do we need to take? Yes. Let's walk that out. What are our actions, our safe actions that we would take in this case for our patient that is at risk for bleeding? Safe actions. All right. Okay. All right. I'm seeing input to stop this infusion. Okay. All right. It may be it may be it's causing him to his blood to be too thin. We may be giving him too much, right? The dose, right? So we stop it, but then what? All right. I see y'all. I see you. I see you, William, and I see you, Sedane. Yeah. Mm-hmm. All right, so we've stopped it, and now what? Yes, 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 yes. I love what I'm seeing here. This means that we're just gonna adjust or decrease, right? The dose. This may be a dose thing. It's just too much of a dose. It doesn't necessarily mean that we need to stop it all together and then change them to a different form of the medication, like oral form or sub-Q, because all of these are just a different route, a different uh, way in which it comes, right? It's still an anticoagulant, but in this case, it's merely just stopping it and adjusting the dose, okay? And decreasing it typically and then resuming, okay? So if that's the case, if we're going to stop it but then resume it, then what parameters make sense here? What makes sense to monitor at this point? What will we want to monitor? What parameters make sense? Awesome. All right. I see twos as a for sure common, right? Makes sense because the APTT was a problem. That's our problem. That's our main problem, right? All right. But what else makes sense here too, right? Awesome. Awesome. I'm seeing fours. I see threes. Now I'll push back on option three. Was the temperature ever a problem to begin with? No, they were good. So no real need to monitor the temperature. Remember, when we monitor things, we want to monitor things that first were once a problem to begin with, right? And then two, blood pressure was not a problem. Temperature was not a problem, right? So these two can be eliminated. Now these two, bowel, was that a problem? Bowel function? No. Remember, his abdomen was good, soft, non-tender. Bowel sounds were great. BM, he just had one this morning. He moved his bowels. That's great. Right? So no issues with any of these other parameters, but why the infusion site? It kind of makes sense. You would ask yourself why, what's going through the site, right? What's going through it? The heparin is, right? So we would want to make sure we're monitoring that site to ensure that there is no, and I'm going to ask the room, infiltration or extravasation that could happen. Give it to me. Give it to me. What we will be monitoring for, infiltration or extravasation. Remember the word extra. Yes, very good. Heparin. Yes, because heparin is a vesicant. Remember the word extra and the wait a minute, extravasation has a V for vesicant. And they are getting an infusion of heparin, which could cause tissue damage if it leaked out or seeped out of the into the surrounding tissue. All right, so yes, we got to monitor that site. Perfect. All right, so this looks good to me, and you did great. This makes sense that we would we would put this patient, um, identify them as a bleeding risk, as evidence of what we see above here, stopping the effusion and just simply adjusting that dose, and then continuing to monitor the serial APTT levels and making sure that site is good. All right. Very good. Excellent. Excellent. All right. We've got one more patient to see, and we're going to head over to him right now. All right. You're doing good. All right. Our last patient for the day. All right. And this is a patient who is actually going to be one of six. So we're going to be able to work our beautiful clinical judgment model and bring that into this today. All right. So I told you that from, okay. We can discuss that. Yes, we'll discuss the sub Q. Yep, at the end of it. Yes, that's a great question that was asked about the previous case. We'll talk about that for sure. Yes. So, all right. So final case, and then we're going to get to the finish here. All right. So we've got our final patient case who this patient is on a telemetry unit. Now, before we get into it and understanding about this patient, we want to know the first thing that they need from us. What do we have to answer? And essentially, this is our first domain where we're asked to recognize cues, right? And this is us asking what matters here the most. So the nurse is reviewing the notes and the EKG results. And they're asking us what assessment findings require follow-up, right? What matters here the most? That's going to require follow-up. And remember, I told you normal typically does not matter because normal doesn't require immediate follow-up, right? So with that said, let's head up to C. All right. So we've got to make sure we read the notes, and we've got to make sure we check out the EKG results. If nothing more, I'm going to tell you to make sure you open up all these tabs. But When in doubt, you must make sure you read at least the note and the EKG, because that's what they're wanting you to base your findings off of. Okay. All right, so once again, we're on our final patient case. The patient is on a telemetry unit, and we are caring for a 78-year-old female with heart failure. And she also has a history of atrial fibrillation and was admitted with dizziness, okay, loss of appetite, and abdominal pain for the past 2 days. So we've got a cardiac history, right? We have a cardiac problem, heart failure, but she's has some dizzy, which is neuro, loss of appetite is GI, and abdominal pain is GI. By golly, what's going on here, right? All right. I would also recommend when you read this brief summary of your patient and they identify the diagnoses, I would challenge you to take a moment to reflect on what you know about that condition, right? Heart failure. What do I know about it, right? And we know that heart failure typically is the heart's inability to pump effectively. It's a pump problem, right? The heart is a muscle. And typically, those who have heart failure or failing hearts, it's because the muscle of the heart is not as as strong or lacks the elasticity, almost like a rubber band, right? A rubber band, if you stretch it, usually if you let it go, it comes right back, right? Um, it snaps back. Well, with hearts that are failing, it's kind of like with the stretch when it stretches to contract, right? Because that's what the heart does. It contracts, it stretches and contracts. When it stretches with hearts that fail, it doesn't snap back well. It kind of has a very ineffective snapback. So this poses a problem with the pump of the heart, and the heart is supposed to push blood going one direction, but typically a lot of times when the heart fails, it doesn't pump the blood effectively going the one direction, and sometimes it will end up doing is backing up. The blood will back up. A lot of times it may back up into the lungs, and then the lungs may back it up into the body, the periphery, right, where we may see the patient dealing with systemic congestion type of symptom. So again, if you take a moment to kind of reflect on what you know, that may help you too to start putting these pieces together. Okay. All right, so let's walk this out. All right, we got a note here that says this client, once again, 78-year-old, she's got that heart failure, she's got symptoms, right? Onset means it's happening now, right? Onset of dizziness and abdominal pain that's been going on for 2 days. I would be writing the abnormal things down. Like when I am reading the case, you can do this too, even on NCLEX. You have a place where you can jot down notes. I would be writing down the things that are abnormal with regard to the patient. All right. And with that said, heart failure and abdominal dizziness, that really doesn't go with that diagnosis. That is abnormally abnormal. Y'all follow me? It's abnormal data that is abnormal for heart failure. So what's going on here? All right. So this has been going on for 2 days. She's also having a lack of appetite. She's not drinking a lot due to frequent urination at night. Frequent urination, y'all, that's GU, right? Urinary. Heart failure. What is causing her to frequently urinate? But let's keep reading. That's something I would jot down. Frequent urination. Maybe that's why she's dizzy. Hello. I'm just saying, we're detectives here. So that's how you got to look at this. The client also reports seeing yellow green halos. So there's some vision disturbances now. And the recent onset of dizziness when standing from lying in the bed or sitting in a chair. Ooh, there's a lot going on here. Client thought presenting symptoms may be due to a recent cold, which she was self treating with ginseng, which was recommended by family. All right. But Client denies having shortness of breath, which is good. Basilar crackles, though, were auscultated bilaterally. Crackles typically equals fluid. Fluid where? In the lung. She's got heart failure. Remember, that's backing up, a backup into that space. All right, so when the nurse listened, auscultation of heart reveals S1, S2, and an S3. Okay, which that's that extra beat there. That's an extra sound there. No murmurs or rubs were heard. Bilateral 1 plus pedal edema was noted. So now we've got some edema, okay, that's in the system. So this patient probably has left and right side heart failure, right? The left side is more of the crackles that we hear, right? That back up into the lung, but the right side heart failure is the back up into the system. So we start seeing edema and so forth. So they have a heart that's not pumping well at all. All right, but their skin is cool, it's dry and intact with tenting, though. What did we talk about in class on the other night? Tenting, right, of the skin. Remember what tenting, when pinched, with slow return to normal and dry oral mucous membrane. Yeah, we saved the best patient for last, right? She's got a lot going on. All right, let's wrap this up here. Vitals are 97.1, heart rate's 85, respiratory rate is 20, blood pressure is 138. Oh, 138 over 78 supine, 122 over 60 standing up. So there was a drop there. Oxygen status 96 on room air, which is great. Our body body mass index is 19, and this client is alert and oriented ×3, person, place, and time. So let me tell y'all, this is real. This can happen. This is a real situation, like a real patient case, like all of this information. And that they're wanting you to be able to figure out what matters the most here, right? So we've looked at the notes. Let's look at the history tab. History of heart failure, history of hypertension, history of atrial fibrillation. We'll look at the medications tab. Okay. Oh, these are some clues right here. She's taking enalapril. So our prils are our what is that family? Your your ACE inhibitors. I want to say prils, lisinopril, enalapril. It's for blood pressure, right? Hypertension. Furosemide, Lasix. It's a diuretic. Mm. She's going to the bathroom a lot. She's losing volume. Digoxin. This drug is used to help with heart failure. It's the #1 drug that's prescribed for treatment of heart failure. Okay. Varoxaban. Somebody drop in the chat what this drug is. Varoxaban. And good old aspirin, we know that to be antiplatelet, so it helps to thin blood and kind of is more preventative for patients that have atrial fibrillation, um, so that it prevents with clotting, right? Did anybody find this drug? Drop it in the chat. What is it? What is it for? What is that drug for? All right, while somebody's finding that for us, then we're going to pop to the diagnostic test. And that's the last tab that we're going to look at. All right. Diagnostic tests, they want an EKG. EKG. Okay. And the EKG was done and it does show normal sinus rhythm, which is great. All right, very good. I thank you for that. This varoxaban is a blood thinner, and it is used to treat patients that may have clots, right? For DVT. DVT is nothing but a clot. This patient has atrial fibrillation, which puts them at risk for developing blood clots, which makes sense why they're getting that medication, period. All right, so a lot of information. Okay, but we can work through this. All right. So once again, we read our note. The note has a lot of information, but in it, there are things that are more critical than others that require follow up. And I want you to determine what those things are by dropping that into the chat, period. All right. So, what are those things that are important here? One, two, three, four, five, six. Drop in that in the chat, and I'll take the majority of your answers based on what we read above. What needs to be followed up on requires following up. Okay, and I'll show as much as I can uh, without obstructing or taking this off. All right. Yeah. Sorry, y'all. Trying to get it on the screen. All right. So, what requires follow up and what doesn't? I got a minute, 20 seconds left on the clock, and we're heading to the next one. All right. Follow up. What requires follow up? Keep those ABCs in mind as your strategy. Keep safety. Remember those strategies. All right, William, I see you. Time is coming down the stretch, guys. So remember, what matters the most is not. All right, let me hit stop. Oh, I didn't mean to hit stop share. Sorry. Hold on. I meant to hit the clock, the timer to stop. All right, requiring follow up. I am seeing a lot of ones so far. But remember, what were the EKG results? They were normal. We don't care about normal things, y'all. We don't have time to follow up on normal EKG results. Mm, I don't think that's going to be the one. All right. So, loss of appetite and abdominal pain. She has heart failure. So, again, heart failure is not abdominal pain and loss of appetite would be something to follow up on because that is not a normal finding. Okay. That's not a normal finding for somebody who has I'm sorry, who has heart failure. All right, dizziness when standing. All of y'all that dropped your answers in, put that in. Yes, we will want to follow up with that. Dizziness when standing, that could be neuro, that could be blood pressure, that could be, what's going on there? Heart failure, is it, what's going on? It dizziness equals perfusion, like a perfusion issue, and she's got heart failure. So we already know it's a pump issue. And then you said 6. Yeah, I would agree. Tensing of the skin. Absolutely. Tensing is slow return equals dehydration. She's peeing a lot at night, right? But remember, she's also on this diuretic, which could be could be the culprit too. All right. So the rest of the things that were there, the heart rate, let's look. Was there evidence that we needed to follow up there? No. Heart rate was great, 85. So was her oxygen sat at 96%. No abnormality there. And the EKG was normal. So remember, your first step of these 6 questions, you are looking for abnormally abnormal, right? Abnormally abnormal. Abnormal things that matter the most. And you can start with your A, B, C's, right? Your airway, your breathing, your circulation, right? Dizziness deals with circulation, right? Tenting deals with dehydration, which still kind of deals with like perfusion or like electrolytes, which is like circulation stuff too, right? So these two are kind of like your C, and loss of appetite, abdominal pain, that's GI. that's still relevant because it has nothing to do with heart failure, right? That's an abnormal finding. Yes? All right, good. All right, let's keep going. All right, so now we submit, we hit to the next one. So the next question says, for us to analyze analyze, what does all of this mean? She's having all of these things going on, right, that are really bizarre, right? The bizarre things, the appetite issue, the GI stuff. She's got some eye stuff. Remember, she's seeing yellow halos and all of these things. She's dizzy and things. What does this mean? So they're asking in this question, for each assessment finding, they want us to specify if the finding could indicate the patient has developed digoxin toxicity or salicylate toxicity, which is aspirin. Remember, she's taking both aspirin and digoxin. So could these symptoms, these new developmental symptoms, be corresponding to an overdosed amount? Which equals toxicity. Well, let's walk it out. Let's check and see. We've got 1, 2, 3, 4 findings. And for dizziness, I want you to put, is this a symptom or assessment finding that aligns with a person who has aspirin toxicity or digoxin toxicity? It could be either or, it could be both. All right. So I want you to drop in. If you, let's see how we can do this. We can do this by putting in, we can call this 1, 2, 3, and 4. Okay, so dizziness is 1, yellow, green, halos is 2, yeah, etc. And then if it's 1, I'm putting it in the chat, and you want to do 1 and S for salicylate toxicity, and you also think that it's digoxin 2, then drop it in like this. I literally sent it to iPhone. Sorry, iPhone. All right, so let me put in S and then D. So this is how it will look. So that's going to help me a lot. So if you do it that way, that helps me. All right. So number 1 equals dizziness. So what we see, dizziness is a symptom of aspirin overdose or digoxin overdose or both. And if it's both, I want you to acknowledge that. What about the yellow green halos? That would be number 2. Okay, so for number 2, what we see, yellow green halos in salicylate toxicity or digoxin toxicity. That's what I want you to do. I want you to walk it out like that. All right. So I'm gonna put the 2 minutes on the clock. Yes, 2 minutes. Good people. And then we're moving on. I was on camera the whole time. I'm using my hands like this. Y'all can't see me. I'm kind of taking myself off and on the screen so I'm not obstructing the view for anybody up in the top corner. So that's why. All right, William is off to a great start. All right, I need the others. I need my nurses. Where are you at? Drop in the chat. Which of these findings, assessment findings, align with the toxicity? All right, and this is our ability of kind of figuring out, what does all this mean? What does dizziness, her yellow green halos, her discomfort, and my loss of appetite, what does all of that mean? Okay, no problem. Okay. Okay, sounds good. Thank you, iPhone. Who's iPhone, by the way? I know you're jumping off, but yeah. What does all of this mean, y'all? Oh, okay. Okay. Got you. I'm glad you're here, and I will be replying to an email. Okay. All right. All right. Sounds good. Awesome. All right. So, all right, our time is almost there. Come on, all I see is William's answers. What does this mean? Let's come on, come on. Come on, come on. All right. Okay. All right. William is taking the lead. All right. Trailblazer William. All right, I see you. All right, we're gonna be all right. All right. So Dane is dropping in hers as well. All right. It would be either no. So so Dana would be like 1. It would be option like 1 and then you would pick S and D, or S and D. It's kind of, or 1 and 3 would be S. Okay, I see. I think I see. All right, so let's let's go ahead and select. Let me see what you got here based on your answers that you put into the chat. Guess what? I'm gonna tell you exactly what it should be based on what the assessment findings are. Let me tell you, for the aspirin or this salicylate toxicity, we will see a patient who is presenting with dizziness as well as abdominal discomfort. That's it. You're not going to see a patient having yellow-green halos or loss of the appetites with the salicylate toxicity. But guess what? For digoxin, all 4 of these are your assessment data right there. All 4. When somebody has digoxin toxicity, they are presenting with GI discomfort, whether it's discomfort, loss of appetite. They also have and can report dizziness as well, but then those halos, visionary changes, photosensitivity, all of those things. All right. So, what you see on the screen is actually the correct way in which we would assess the findings for both of these conditions. All right. So, looks like her symptoms assessment findings are aligning with this. She took too much of this, which is the treatment of choice for this heart failure, right? But it's led to her having these symptoms. Okay, so we're uncovering the clues here. We're detectives. All right, so let's head on to the next question. All right, so what do they want from us? All right, question number 3 says the nurse is reviewing the notes where there's no additional notes right now. So they also want us to review the lab results. Oh, so that's a new one. And then to develop a plan for this client. So once we look at the lab results, we know what the note says here. It says the client is at highest risk. Okay. We have to prioritize. What is she at highest risk for developing right now? Is it dysrhythmias? Is it renal failure? Is it anaphylaxis? Okay. That's one section due to the client's blank. And mind you, we're going to have to look at the labs to kind of make a connection, right? Is it due to the client's blood glucose level, right? Cardiac exam or potassium level, all right? And then finally, and serum creatinine, vital signs, or digoxin level. All right, so again, we're now trying to prioritize what our patient is at highest risk after reading the note, which we're aware of. But now let's check out the labs. All right. So here we'll go to the labs and we'll see what that looks like. All right. I love the fact that the case studies gives us the normal ranges. Love that. But you still need to know what your labs are because they may not always give it to you in the regular questions, right? The normal select all that apply multiple choice, right? Well, in this one, they give it to us. All right, so let's check it out. Serum digoxin. Her level is 2.1. The norm is 2, up to 2, right? 0.8 to 2. So there's a little elevation there. Serum sodium, 138. That's within the normal range. All right. So no sodium issue there. Potassium. Ooh wee. Ooh wee. That number will make you want to sing. I took my camera off because I don't know if I'm obstructing the view of the range of labs. I'll bring it back up in just a bit. All right, that potassium. Oh boy. The norm is 3.5 to 5.2, and hers is 2.9. But guess what? Oh, well, before I talk. This what you will want to ask yourself, why though? Why is the serum potassium so low? All All right, serum chloride 99, that's normal. Serum calcium 10.2, that's normal. The BUN is 19, which is also normal, and your creatinine is 1.0, also normal. So are we dealing with a kidney failure or any of those issues? We don't have an issue with the creatinine or BUN. All right, and the glucose is 94. All right, and Norman's, I guess anything less than that 110, that's normal. And then the salicylate level is 102. Guess what? It's normal. So she doesn't have an aspirin toxicity because it's normal. The things that stood out to me and hopefully stood out to you that were abnormal findings, guys, were the potassium was low and the digoxin was higher. It was higher than the norm. So that's a big deal. Okay. So what does that put our patient at risk for developing? Digoxin is high, potassium is low. And what do we know about potassium? Whether it's high or low. Mm. Yep. The low K came from the diuretic. Yes. Yep. Yes. But what do we know about potassium? Do we know that whether it's high or low, what does that put our patient at risk for? Developing what on that list right there? No, not renal. Her creatinine and BUN were perfect. They were good. Dysrhythmias. Yes. Potassium is has everything to do with the pump of the heart. It helps with the pump of the heart, right? So when you have too little of it and too much of it, it can cause the heart to kind of get out of like disruption, just be disrupted. Dysrhythmias is the problem. Okay, that's the problem. Okay, so the client is at risk for developing dysrhythmias due to the client's what? What is the direct connection there with the dysrhythmia that I just said? I gave y'all the answer. The potassium. Yes, it's too low. It's too low. Yes. And not only is the client's potassium low, right? But then the other issue for the dysrhythmia issue is because of what else? What other level was, yes, the digoxin. The digoxin level was up. And let me tell you something, a fun fact or quick fact about digoxin. Digoxin is a drug that you have to, if a patient is taking digoxin, you have to keep your eye on potassium. Those two have a relationship because when one is low, like potassium, the other goes high. The problem with digoxin is we want it at a normal level. We don't want it too low because it's then going to be ineffective, right? It's not going to help with the snatch back or the snapback of the heart. And we don't want it too high because it will be ineffective as well. And we want it within therapeutic levels. Okay. So anything, so we know the range is 0.8 to 2. I don't want you to forget that. But when a patient starts to go above 2, just like the patient did in this case, she's 2.1, even that little bit creeping up can cause the patient to have the symptoms that she's displaying in this assessment. All right, so when potassium is low, like a seesaw, think about a seesaw. When the seesaw is low, right, and what's high? The digoxin. So when potassium is low, digoxin is high, and that puts your patient at risk for toxicity. All right. But why would she have low potassium? And it came in through the chat. Yulia said it. Why would this patient have a low potassium based on the medication she's taking? What's causing her to get rid of the potassium based on the medications? And Just FYI, I know I'm past the time. So if you do have to drop off, I understand. It is recorded, so it will be available in the hub later today under the home page. But if you still hang with me, I'm here with you too. I'm hanging too. All right, and this is going to be our last patient. So, yes, the furosemide. This right here is not a potassium sparing diuretic, right? It's a diuretic. So whenever we go to the bathroom, we naturally, when we urinate, we actually urinate sodium and potassium. And what she's doing is that she's doing just that. So when she's taking this diuretic, it's causing the potassium to be wasted or excreted in this case, which now has brought her levels down, right? Her potassium is low, but she's also taking digoxin. So the seesaw, that potassium is going low, the digoxin goes high. And that's what we're seeing here with this patient. All right. So, patient on digoxin, always check your potassium levels. Okay. So, boom. This is perfect. This is the correct way that it should be. She's at highest risk for developing dysrhythmias. Once again, if you've got low potassium, high potassium, guess what? That puts the patient at risk for all kinds of dysrhythmia action, right, to occur. All right, so let's go ahead and submit this and hit to the next one. All right, so, all right, same patient, no new notes. The nurse is collaborating, meaning working with the healthcare provider on the plan for this patient. So we've got to figure out which orders should the nurse anticipate in the care for this client. All right, it kind of makes sense. What would I anticipate based on what's going on with my patient, right? All right. We got 1, 2, 3, 4, 5, 6, 7, 8 options. This is that extended multiple choice. All right. What will we anticipate that happening for this patient or being ordered by the provider? What makes sense here? What's logical? All right. So I'm starting the timer. Drop in your answers. We got 8 options. So drop in what makes sense, nurses. All right. We're almost done. And I appreciate you all. Oh my gosh. Thank you. I was talking a whole lot and you couldn't hear me. Okay. So I was saying that you all put in some great answers. So I was kind of walking out what makes sense here that we should be doing for this patient. The serum digoxin levels. It makes sense to monitor that because it was a problem to begin with, right? It also makes sense to provide education to the patient on medication safety, especially um, if she's taken too much of the digoxin, just giving her some education in general. The word safety, I like it because this is a safety exam that you're taking in doing these questions, but it's important to roll that over into the real practice too. We should be giving our patients education on their meds, right? Restricting fluids. I don't think I saw that answer come in at this point. That's not an option that we would need to take. Performing a med reconciliation, I think that's reasonable. Med reconcile, when we reconcile, this just basically lets us know what she's taken, when did she last take it, how long ago, um, if she, what dose, etc. It gives us information so that we don't overdose that patient. If the patient took all our meds this morning, guess what? We're not going to give her all her meds now because she already had them. But that's where the reconciling process comes in. So we will be able to get that information when we ask her, when's the last time you took your medication, the dose, etc. All right. Yes, we need to put her on a monitor because she's at risk for developing dysrhythmias because of her potassium levels. Holding the digoxin. Yeah, it kind of makes sense to do that because it's elevated. She's got too much. And then to keep our eye on the electrolytes makes sense to monitor the potassium. It also makes sense to me to give potassium as well to this patient. I will tell you that we're going to go ahead and select it. And to me, this looks good. All right. So um, it looks pretty good to me. So we'll take these options and we'll head to the next question here. We're almost done. I think we're almost done. We're wrapping this up. All right. So with this said, we're now, I want to say on 5. Yeah, we're right there. We're almost there. So we're at the point where we're taking action. So this is where we're going to be doing some actions. Looks like we have another note entered, and it tells us the nurse has reviewed the nurse's note and orders from 9:30. So we must read this new note. And they're asking, which action will the nurse take? So based on the reading of the note, let's check it out. So this says, at 9:30, the nurse reviewed medications with the client who stated, I am taking too many pills. Do I really need them all? Client states it is hard to track which provider to see to renew each of these meds and which pharmacy fills each med. So she's all over the place, right? It's hard to do. The client also asks if the diuretic can be taken at another time of day to avoid getting up at night to urinate. That's a reasonable question, especially if she's going to the bathroom quite a bit. So this is a new entry here. And then they want us to also take a look at the orders. So let's check out the orders that came in. Ah, okay, infused potassium. Okay, this is infused means to give it by IV. So she's going to get an IV infusion of the potassium, and the doc wants us to hold the digoxin. Makes sense. Makes sense. Okay, so we looked at the orders. We checked out the note, the new note. Okay, the new note. And based on the note and the orders, we're asked to figure out what action we're going to take at this point. All right. Once again, select all that apply. What actions does the nurse take? 1, 2, 3, 4, 5, 6, and 7. We've got 7 options. I'm gonna stop my timer so you can see it on the screen. And I want you to tell me what you think. What actions make sense? What do we do at this point? All right, let's do it. Let's do it. What makes sense here to do? The other screen is small. Okay. All right. Let me close this. All right. About 30 seconds on my side. What you think? What do you think we should do? What makes sense here? All right. Okay. All right. So the timer is off. All right. Very good. So I got some answers here. See you, Johan. I see you, William. Okay. Your answers are very similar in terms of what we should do for this patient. All right. So action wise that we should take for our patient. Definitely. I do agree with encouraging the client to use one pharmacy to fill her medications because that can essentially decrease the confusion, right? The different prescriptions. She's picking it up over here, picking it up over there. Definitely is appropriate there. All right. The other one, instruct the client to contact the provider before taking the herbal supplements over the counter. Yes, because a lot of times these medications can have contraindications, right? With the prescribed meds, it can cause some side effects. It can cause things like that. All right. So two makes sense as well. All right, and I see you, Sedane. All right, and it looks like the majority, 3, 4, and 5, were chosen as well. So I'm going to go ahead and take it 3, 4, and 5. All right. No one chose 6. 2.9 is our potassium. I think this will be reasonable to go ahead and give her the potassium. And guess what? It was ordered. It was an order, right? Infuse means infusion. And guess what? You must always infuse potassium on a pump. So I'm going to add to this here. And I think everything else looks good to me. 1, 2, 3, 4, 5, 6. Yeah, everything is this is appropriate right here. Yes. 7, encourage the client to drink at least 500 milliliters of fluid each day. I don't know because she's got swelling. Remember, she had some swelling going on. She's got a heart that doesn't pump. When we drink, that adds volume, and the heart's got to pump that volume. So I actually, a lot of times, patients that are heart failure patients, they actually are on fluid restrictions, and I think this is a lot of volume for a patient who has heart failure that already has. Okay, dehydration. Yep, I'm with you on that, girl. The dehydration, though, I think is also related to the diuretics. So I get it. I do. I'll take 7 just because it's a majority. The majority, well, 2 of you have chosen 7 plus 3. So we'll go ahead. We'll take them all. And I'll say to you, guess what? Can you have a question that has all of them, the answers? You can. So don't be like, oh my gosh, I can't select all of them, right? Because that's probably not the case. And I am going to tell you there is one answer that is selected that is not right. But there are questions that can have all of them selected and it is okay. All right. So we're going to keep it like this because we're getting ready to debrief in just a moment. But let's submit it and take it to our last and final question. Once again, this was measuring our ability to take action. And we did that about what will we do? We just did it. All right. Final question of the night, of the day, period. All right. This is our final question. So it says the nurse is preparing the client for discharge. All right, our lady's getting ready to get out of here. She's going to be discharged. She's probably happy too. What assessment findings indicates an effective outcome? Now, remember in my class, I believe it was my night class the other night, 211, February 11th course. Um, we were talking about when we look at these options that it, it may align with what's up top, but we're gonna make sure that we take what's here. Um, this makes sense that it's all going to align with this note. It really does. So let's just take a listen. I mean, let's just read it and let's kind of see what they say. All right. So once again, we're looking for assessment findings that's indicating effective. Effective equals positive outcome, right? That the patient has had. All right. Discharge day. Client no longer reporting dizziness. Hmm. No longer reporting abdominal pain. No longer reporting seeing halos around the objects, right? Wow, that's very good. Vital signs: temp is 97.1, heart rate 80, respiratory rate at 18, blood pressure 132 over 74, supine, and 128 over 72, standing. The skin returns quickly when pinched. Oral mucous membranes are moist. Client states they will transfer all meds to one pharmacy. How about that? Our teaching was helpful. Client feels that the best time to take the furosemide would be after returning from an early morning daily Tai Chi class. That's nice. When they are generally home for a few hours. All right, so they're going to do it in a day instead of nighttime. Okay? Client verbalized the need to reduce potassium in the diet. Okay. Client also is okay. Client also verbalized not taking any medications without checking with the pharmacist or healthcare provider. All right. So that's pretty decent note there. So let's go down and take it from here. All right. So once again, we're asked what assessment findings indicates that an effective outcome has taken place. Once again, one more time here on the select all that apply. We've got a 1, 2, 3, 4, 5, 6. Um, 6 options. We can go ahead and actually take a look at the labs really quickly, just because the digoxin level and serum potassium level are listed. So are the blood pressure. So let's take a look really quick of the lab of the potassium and the digoxin. It's still the same. And I thought it might have updated labs, but it's still kind of our same. However, okay, digoxin was 2.1, potassium 2.9. Okay, all right. So, okay. So essentially, indicates an effective outcome. Serum potassium level, serum digoxin level. Hmm. I wonder if you're interpreting this as the level that was taken, or I don't know. I'll be quiet. I may be overthinking. I'm gonna let you do and determine what you feel would be an effective outcome. I'm gonna be quiet and I'm going to give you the final 2 minutes on the clock to walk this out. All right. Yeah, I'm gonna leave my thoughts to myself because we're getting ready to debrief and wrap this up. All right. So, what do you think is effective based on these options? We've got a 1, 2, 3, 4, 5, 6 options. I want you to drop that in the chat. Final question of the day. All right. Final question of the day. Let's do it. Let's do it. It's it's basing it off assessment findings. It's not basing it off the actual labs, the old ones. It's saying which assessment findings indicates an effective outcome. So yeah, what if yeah. So yeah. Okay. I'm gonna be quiet and I'm gonna take my video off. All right. Okay. All right. William, I see you. Johan, I see you. All right. The time has ended. Okay. Okay. So you know what's really nice? So what we would want, yeah. So this was a little tricky because if we were simply basing it off of the level itself, then we would not be choosing these levels, right, as being a finding that shows an effective outcome, right? If we were going under the lab itself, but they wanted you to take the patient's assessment finding above, okay, and interpretation. That's what they want you to do. Analyzing that if the patient is no longer reporting the dizzy, the pain, the abdominal pain, or halos, right, or seeing halos, this means that their digoxin level has improved. Even though we don't see the value, we don't know the actual value, that is an indication of an effective, based on our assessment. Patient tells them, I don't see halos anymore. I'm good. You know, that's saying that if we were to draw a new set of labs, we would probably see the digoxin returning back to that normal range based on the assessment. Does that make sense? So if you did choose the digoxin serum level, that is correct. Okay, based on the evidence that the patient is no longer reporting these outliers. Okay, the fact that the patients, let's go to the potassium level. Client feels so. Let's see. Skin is quickly returning back. That's skin returning that. Okay, or the serum level, it would be best to kind of say that these two, they kind of go hand in hand. I told you, once you have basically normalized the digoxin, the potassium is also, it affects the digoxin. But if we're back to normal on the digoxin level, we're we're likely back to normal on the potassium level. I'm just trying to make a connection as to what could possibly be related to the changing in the blood pressure that could have caused the issue. The fact that the orthostatics are better, that's one. The use of the pharmacy, that's definitely one that's effective. Skin returning quickly is definitely one. Um, the patient does not need to reduce. If anything, they need to increase, right, their potassium intake through their nutrition. So that one would not be correct. So the rest are actually correct. All of these are correct choices based on the assessment findings indicating effective outcome of the treatment. Okay, so this is good. Mhm. All right, let's go ahead and submit. I'm going to submit this response this for this item, and we've now seen our 3 patients. And we're going to just quickly debrief, have our discussion, and then we're going to take it to the end. All right. All right. So, of all of the work we did today, I love the fact that we're given, look at how many points we got, versus, we got some partial scoring for some things that we took, and we did good. This is a great. This score at 34 out of 38 is an excellent scoring. So kudos to you all. With our first case, remember this was that 27-year-old. We started in the ER. Had the nausea, vomiting, diarrhea. Remember, I told you there's so many things that could be, right? But upon reading the assessment and pulling out the things that were really sticking out, right? The constricted pupils, the significant pain, right? Muscular pain, which is like consistent with the flu-like symptoms. Then we add on the irritability, the restlessness, right? They're yawning frequently. If you ever see that, that's like a hallmark sign for someone who is going through an opioid withdrawal. And then NCLEX loves to slide in some risk factors, right? Homeless, divorce, lost their job. All these are predisposing them to stressors, right? And sometimes when patients have stressors in their life, they resort to coping, right? Certain coping mechanisms that may not be the most healthy, right? Or most positive. So taking opioids to numb the physical pain as well as the mental pain is sometimes what we see when patients take opioids. But in this case, he has a history, right, of substance abuse, abusing the substance. And in this particular presentation, he's denying use of it. So now what we see is a patient. Think about opioids. When you take an opioid, what sympathetic system does it affect? I just actually it affects the parasympathetic. Opioids relax, it calms everything. But when you take it away, right, from a person who's used to having it, the patient's going to have symptoms that are the opposite, right? Everything's up now, right? Right? Nausea, vomiting, diarrhea, they're restless, they're irritable, they're yawning constantly, right? So that's what we're seeing. We're seeing somebody who's used to taking the opioid, right? And in this case, abusing it, right? So overtaking it or taking it. And now they're presenting with these symptoms because they don't have it. Maybe don't have access to it. Maybe they, so now they have these symptoms and they're the opposite effect of what opioids do to the body. So with that case said, we had to figure out all of this, to analyze and come up with what is the priority issue, and we were correct in opioid dependency. All right, so on this side, it says that we should have action-wise taken, put them on a monitor, and also obtain a urine drug screen. Now, I let you I actually knew that this one was correct, but I went on and went with it because I knew that the majority of you chose this. But what will the drug screen show us? Maybe anything else that's in the body that could be also causing these symptoms, right? In lieu of the history of substance abuse, we as nurses want to always get some type of drug screen because then we can see what the patient may also have in their body or in their system that could be contributing to the symptoms we see. All right, so on the other side of this, we will be monitoring their cardiac and respiratory function. So remember, opioids, they suppress or depress the body, right? The body relaxes and goes into this relaxation. We take away the opioid and now everything goes up. So heart rate will go up, right? Respiratory rate may also go up in the presence of withdrawing from the opioid, right? So we want to monitor those things. These are part of our assessment. And we also want to monitor their nutrition and hydration status as well. And this is Maslow's basic hierarchy right there. This is a Maslow strategy. This is your ABC right here. Airway, breathing, circulation. That's the strategy. And this is your Maslow. Fundamental. This patient who's going through these things, they're nauseous. What else were they? They were vomiting. Well, that may affect, and their diarrhea. That's going to affect their intake, right? Their nutritional intake. If you're nauseous, you're vomiting. And then if you got diarrhea, that's likely to affect your electrolytes, right? You're losing volume, both directions, vomit, diarrhea. So we would naturally want to what's the word? To monitor that. All right. I don't believe we had any issue with the renal functioning above being an issue. Remember, nausea, vomiting, diarrhea, that's GI, right? Did we have any issue with GU? History, substance abuse, nothing about that GU was even mentioned that we would need to monitor, so that's out. And nystagmus, I think that's like just eyes that kind of like quiver or kind of that does not connect with opioid withdrawal as a symptom to monitor. All right, so this is your why. All right, and again, one thing I always tell you all to do when you're doing these cases is to read the explanation. And even if you got it completely right, the explanation gives a lot of depth to this. All right, and you heard me kind of talking through this earlier that this patient was displaying the opioid dependency because they're going through a withdrawal. That's what we see here. And in time, a lot of times these withdrawals can begin 2 hours, as early as 2 hours after they last used it. So they used it 2 hours ago, but now their body wants, kind of desires it more, more of it. So if without it, they may start having these symptoms, right? And symptoms that we saw were the muscle aches, the nausea, the vomiting, the diarrhea, the constricted, that equals withdrawal, right? Constricted pupils, irritability, everything up, restless, right? Irritable, frequent yawning. All right. And remember, these were risk factors, lifestyle things, occupation, lost his job. He was homeless, divorce. These are risk factors. So all of that was going on. So the withdrawal from opioids can cause cardiac function to include cardiac and respiratory arrest, right? It could stop breathing, heart could stop. Okay. So the nurse would need to obtain urine. Once again, that's going to tell us what's in the body, what's in the system. All right. And it also will help the provider to make a diagnosis and then ultimately treat the patient and the nurse to develop a plan for the patient. All right. So again, we said the hydration and nutrition was important. We want to monitor that, and so forth. All right. So, and then why I like these is because it will give you more context as to the other ones, right? The methamphetamine. It'll talk about how if alcohol withdrawal was the issue or even benzo withdrawal, that really puts your patient more at risk for the seizure activity, right? More so. Seizure activity is generally not a complication if you're with me down here. It's generally not a complication associated with opioid dependency, nor is nystagmus. Okay. But nystagmus could be present with methamphetamine dependency. Okay. Opioids are broken down in the liver, not the kidneys. Therefore, liver functioning would not be important to monitor either. All right. So, a lot of good stuff there, right? We can comb through this and learn a lot from just reading this. All right. And the remediation on this particular one was opioid use. And if this was something you struggle with, this might be a good remediation or good thing to review on opioid withdrawal and how we manage the patient. All right. All right. Another one was our next patient. We ended up moving on to the patient that had the DVT and was on heparin. And we realized as we were reading the note that nothing was really standing out to us until we got to this last line, right? With the patient having a very high APTT level, right? Which was 82. So that put our patient at risk for bleeding, which means that we need to take action, stop the infusion, decrease it, the heparin dose, and then resume it. And then we need to monitor the infusion and as well as the APTT sites. And to really quickly kind of recap, once again, we saw that APTT results indicates hyper anticoagulation, which puts the patient at risk for that bleeding. All right. And so when the patient is on heparin, there is a protocol that we follow as nurses, and we have to monitor like serial APTTs so that we know that the patient is being or receiving effective treatment, right? And we're only going to know that based on the levels, okay? Based on the level of their APTT and the serum levels of the medication that will ensure adequate anticoagulation. Again, the heparin is based on the patient's weight. It's titrated. The word titrate means to adjust. We can adjust, right? If he was getting 16 units, we may have to adjust it to getting 14 or 12 or whatever. But there's a protocol that we would use or look at based on the patient's blood, we would look to see where we would have to adjust if needed. All right. And once a PTT, once again, we would be doing serial monitoring of these. So every 8 hours, we're doing another one. We're doing that. For anybody's on a heparin drip, we're doing serial blood draws to check the APTT. And once the patient APTT has been maintained effective at a therapeutic level, typically after starting the heparin 24 hours, right? So they've been on the heparin after 24 hours, they've been therapeutic, then that's when the patient can be switched to an oral or sub-Q anticoagulant therapy. That answers your question earlier, Yulia, that you presented. Um, when do we do the sub-Q, right? The patient has to be therapeutic on that heparin for 24 hours. So if we drew a APTT 8 hours and then 8 hours later, we drew another one, and then 8 hours later, we drew another, and each time the patient was within the normal therapeutic range, then by the 24 hours they've been on that for a day, then we can start anticipating that the provider is going to likely start to now switch the patient into now a sub-Q, like a Lovenox or some type of heparin injection sub-Q. And remember, once they start to switch, then we stop the heparin, and then the patient ends up going home, likely on an oral form of heparin, which is warfarin, right? And warfarin, aka Coumadin, is still something that patients will have to have checked as well. They need their INR checked to make sure their levels are still good, even on that oral medication. All right. And so again, in this case, the level PTT was 80 something, right? I think it was 82. That's a long time. And please remember that 80 anything. So with that, we had to stop the heparin. So remember, a level that is greater than 70 seconds, okay, uh, it equals a critical value. And this puts your patient significantly at risk for spontaneous. That means that they can bleed spontaneously, right? And we have vessels that run all through our body, eyes, brain, everywhere. So people that are or patients that are greater than 70 seconds, they can start bleed everywhere. Gums can bleed internally, like urine, uh, GI bleed. So this is where we will be teaching our patient about the risk factors, right? And to report any signs of bleeding, because bleeding like that equals the likelihood that their APTT levels are too high, which equals an adjustment on the dose of the medication. They still need to have the thinner, the anticoagulant, but it just needs to probably be adjusted, aka titrated. All right. The healthcare provider would be notified of the lab results, and essentially we will let them know. So in this case, the second action would be to taken to resume the heparin after 1 hour and then decrease it by 2 units and restart it. Okay. So that's part of the protocol. We hold off 1 hour, and when we go back to resume the heparin, it's down, decreased by 2 units. All right. So again, that is the gist of the summary of that. And again, it's very good to kind of make sure that we are looking at the rest of it. There was an option for dehydration, but there was nothing that supported a diagnosis of dehydration, right? So again, we always want to make sure we can connect back up in the question of problem or evidence, assessment, information that connects you to the diagnosis. It's got to be there. But because otherwise, if it's not there and it doesn't support the diagnosis, guess what? That ain't your answer. Okay. All right. And then finally, good people, remediation on this was heparin. So once again, if this is a question you struggle with, it may be good to dig in a little more into heparin if you choose to do that. All right, final question of the day was our patient who was an older lady, once again on the telemetry unit for heart failure. And she had a bunch of symptoms, right? Dizzy, that's neuro, appetite, abdominal, that's GI. And that was happening for days. So we were like, what's going on? And then we combed through all of her history, the meds she was taking, the tests she took, and realized, guess what? Not only Not only did we have concerns for the assessment, we were supposed to figure out what required follow up immediately, right? Based on our assessment. And we chose correct, right? The fact that she had a loss of appetite, that's abnormally abnormal to heart failure. Does that make sense? She has a diagnosis of heart failure. That is an abnormal finding to have an appetite issue and pain. That's abnormal in and of itself. But it's also abnormal because it does not connect with the heart failure. We've got GI, and then we've got a cardiac, underlying cardiac issue. So something's wrong there. That needs follow up. So does the dizzy. Dizzy equals a perfusion issue, likely a blood pressure issue, right? And blood pressure equals cardiac. So this is an abnormal issue that does possibly connect us to the heart failure, right? Because heart is cardiac. Cardiac perfuses, right? Blood moves blood. Dizzy tends to deal with a perfusion issue, right? It does. So yes, that's something, and so is the tenting. We said that was likely due to dehydration, which still is dealing with like perfusion because that's the fluid and electrolyte. Hello, dehydration. Where is that fluid flowing? It's flowing through the vessels. So still cardiac, yes, kind of dizzy from a neuro, but the underlying issue is probably perfusion, still cardiac. And then we've just got a whole like GI thing going on that shouldn't be there. And then the other things were not even abnormal. So we didn't have to worry about that. So we were able to successfully recognize the things that mattered the most and needed follow up. Then we went to the second one, analyzing cues. And we had to figure out these assessment findings, what did they line up with? This was all her assessment findings. And we had to figure out of these two things here, too much digoxin, too much salicylate, which one aligns better? And all of these are symptoms of digoxin toxicity. All right, period. All right, the other thing that we had to then move on to was to prioritize. Okay, what are we doing about it? Okay, and not only what are we doing about it, but kind of where do we start? But where do we start is identifying that she's at highest risk after we looked at her labs, saw her digoxin was high and her potassium was low. Think of the seesaw. We put her at risk for dysrhythmias because of the low potassium, right? And the fact that the digoxin is high. So those two together really puts her at risk for dysrhythmias, right? So that was our assessment there. All right, number 6, we had to go to solutions. Okay, what can we do about it? So everything was correct here. This is interesting. And even when I was like looking at it, I was like, why wouldn't that be right? Because her potassium is low. Why would it would make sense to give the potassium? So I was thinking that maybe that why this was wrong is because it was PO form of potassium. I don't know. This to me, I would have selected it because there's a low potassium to begin with. It makes sense to give potassium. It doesn't specify which route, but she needs potassium. So I would have chose that. I would have chose everything. When I did this case, I chose everything except the restrict fluids. I don't want to restrict fluids. She needs fluids. I don't want to restrict it, but I did choose this. So um, maybe at the end we'll see why. I don't even know if they gave a real good reason why we shouldn't have chosen this one, but I chose it and you did too. So essentially, we do end up giving her potassium on the next one. Take action. I don't know if you remember, but we did give her potassium because the doctor ordered the infusion of potassium. Okay. So again, we gave it. But remember, I was telling you that one of these answers were wrong. And this right here, the volume, the amount of 500 milliliters of fluid is essentially too much for someone who has heart failure. Okay. And we're saying at least 500. That means the patient would drink even more than that. With a heart that is failing, we limit fluid intake because the more they introduce, the more the heart has to pump that around and circulate it. All right, but everything else was correct, and you did great with that. And then the final option here was evaluate. So evaluation, We were spot on. We had to evaluate effective, which assessment findings indicate effective outcome. And they wanted us not only to just think about the digoxin level, okay, that was, and the potassium levels that were not great, but based on the assessment of our patient now reporting, you know, no dizziness, nausea, vomiting, no longer having the halos or vision changes. That's indicative of her digoxin levels have stabilized, which if the digoxin stabilizes, typically potassium will too, especially since we were already giving her potassium back now, right? She's getting the potassium. Okay, so overall, it was great. Overall, we did good. I think that we can just take a few more things from this. It says I'm trying to see why they didn't want us to give that. Um, that potassium. The class is normal and does not require follow up. The saturation, all that's great. Bodies require follow up. So that's in the very beginning. Let's see if we just get a quick summary. Yeah. Okay. So, okay. All right. So recognizing that her most serious cues needed immediate things we indicated: loss of appetite, abdominal pain, halos, orthostatic hypotension, and self medication with ginseng. Compare the events related to serial drug. In this case study, digoxin toxicity and salicylate were compared, identifying prioritize the most likely event here. Hold on, I'm trying to see. Understand plan. Clients at risk for dysrhythmias due to digoxin level in the toxic range and hypokalemia. All right, here we go. Generate solutions by anticipating that this client will need digoxin held until the levels are drawn. Sorry, until the levels return to normal. Correction of the hypokalemia, which again, that's why we would have chosen give potassium. Monitoring the digoxin and serum electrolytes up, promoting hydration, cardiac monitoring. Da, da, da. Okay. Taking the action, giving the IV infusion, and providing hydration. So it's very vague in this case. The medication needs a thorough review because they are taking two medications. This is a good catch. The Varoxaban, which is to help thin the blood, a lot of times used for DVTs, as Yulia put that in the chat earlier. But aspirin is an antiplatelet, thins blood too. So these two together increase the risk of bleeding. That's good. That's a good catch. Taking the diuretic in the evening is interfering with sleep, which then promotes the client to reduce fluid intake, leading her to dehydration. Things are unfolding. So she doesn't want to get up and interrupt her sleep and keep going to the bathroom. So she's not drinking much, which led her to having the dehydration, the tenting skin, all of these things. But if she starts to take that diuretic in the daytime, she can consume drinks, but it won't interrupt her sleep because it's during the day. All right, the ginseng. Herbal ginseng may potentiate the effects of digoxin. So digoxin and ginseng don't go together. All right. This is why I love reading these, because once again, you get more information as you go. All right. Once again, da, da, da. All right. All right. So again, this is a takeaway. One last thing I do want to give you as a takeaway on this, on the digoxin itself, the digoxin drug itself, is the fact that when you look at this, the word, there are three things I want you to write down. If you're able to do this quickly, because this will like also cement what we did today. One thing I want you to always remember about digoxin, obviously we know that it helps to increase contractility of the heart. As I told you, the muscle is the heart is a muscle that contracts, right? It contracts like a rubber band. You pull it back, it snaps back. And pull it back, it snaps back. But hearts that fail have these very weak hearts that when you stretch that rubber band, it may be slow to snap, slow to snap back. So digoxin helps with the snapback. I call digoxin my snapback drug. So number one, though, when we give digoxin, you have to check the heart rate. So the patient's heart rate has to be checked, because the three letters in digoxin that says dig, that means something. When we dig into like the ground, right? We go down. The D stands for down. Dig goes down, digging down. Digoxin digs down the heart rate. So if a patient's heart rate is 60 or less, we're not giving digoxin because it will further dig down the heart rate. So that's number one, I want you to take away from this word. Number two, I want you to take away that there are two-letter I's. Two-letter I's. And what's the significance of that? Digoxin toxicity, one of the hallmark signs that may be put in questions are eyes. Eyes, something that the patient's complaining about with their eyes. The two eyes, seeing double vision, photosensitivity, these halos, these green, yellow things going on with the eyes. Anything with eyes, that's a sign digoxin toxicity. They have digoxin toxicity. Okay. And the last thing that I want you to take away from this word, digoxin, I'm going back to the two eyes. How many eyes are there? Two. So anything over two puts your patient at risk for digoxin toxicity. Your book says like 2.4 is really when you start seeing like the symptoms. But as we saw, our patient was 2.1 and they were already having these symptoms. They were older too. So that's another thing. Patients who are older tend to have a lot more adverse reactions to medications, all right? Especially digoxin. So two eyes means anything over two for digoxin is toxic. Two eyes means that if my patient has anything eye related, that's a sign that a patient has toxicity. The other sign of toxicity for digoxin is what's down. When we think about down, what's down below our waist? Well, maybe not our waist. Let me go. What's further down? The belly, the GI, those GI symptoms, nausea, vomiting, pain. That's signs of your patient having toxicity. So GI and I. Oh, that's good. G and I and I and I. So eyes and GI are going to be in hallmark signs that your patient is having digoxin toxicity. All right. And then finally, dig. We got to check the heart rate always because it can drop that heart rate, lower it. Okay. All right. So that's what I wanted to take and finish up with that. I hope this was helpful. I hope this was helpful today. We got a chance to dig into three very good patients today. I really do hope that it was helpful. Once again, that's why I do this so that it can bring us together in between our time that we're um, are not together. This can be another place that keeps you motivated, keeps you going, helps you with seeing certain things that I might point out, or even that your peers point out. Does anybody have anything that they have a question about or want to, touch on before we say goodbye? Yes, you're very welcome.
Hi, Mr. Joe. Not about this, but um the video for last week, um the homework you give us, I forgot the VS something.
So real quick, before you touch on that, I want to make sure that any questions related to like this right now, because if
Uh,
it's not, will stop recording and then I can answer anything that's separate, like assignment wise in that moment. So once again, I'll just ask the room if there's any specific questions related to the anything we did today, question wise, any of those things. If it's not, it's quite fine. um, because at this point, I'm gonna wrap us up with this session. I will hang back for anybody that needs any additional questions answered. I'm happy to do that. But I do want to just emphasize that you got this, and that the more that you practice these case studies, the better you're going to be with them. The more that you keep at it, it's going to get better. So I want to just remind you that the goal ahead for many of you in this room is to retake that NCLEX and pass it on your next attempt. That's what we want to do. 2025 is your year. We just got to work to get there, and we are. So I want to remind you that you are unstoppable and you will do it. You will pass your NCLEX. And we're going to do it together. All right. So again, I want to thank everybody that took the time, extra time, to hang out with me today as we went through the next gen case studies, and as we went into the Nurse ED 101 hospital and we were taking care of those patients. together. So thank you again for that. I appreciate you. The next Thirsty Thursday is next Thursday. So you're in for a treat. So if you're wanting to get more, what we'll have a new topic for that week. And that will probably be one of the categories, one of the client needs categories that we um, will do for next week. I believe the last time we did it, we were doing prioritization. We'll do something, potentially next week, maybe infection control. It'll be more like question based. Today was a little longer just because it was the case studies. And so, yeah, but next week, join me, same place, same time. And I look forward to that. Other than next Thursday, I will see each of you either next Monday if you are in my December cohort, and next Tuesday if you are in my February cohort. All right. I want you to have a wonderful day. Make it count, make it matter, and you got this. Stay encouraged. All right. So I am gonna stop sharing and I'm gonna stop recording, and I will stay back for anybody that has any additional questions that I can answer unrelated to this session today. All right. All right. So let me
Mm,
stop recording. Give me 1
Can I
second.
ask you a question unrelated to this?
Okay. Give you 1 second so I can stop the recording. Give me 1 second.